Morning, everyone. Thank you for coming. Quite a lot of you here today, which is good, and I'll get straight on to it. Just a quick introduction to everybody, particularly those of you who don't come to too many of these public briefings. This is not a board meeting, this is not a public board meeting, this is an opportunity for us to let you know what's going on at the moment at our hospitals in terms of our performance and in various other matters. And today we are able to give you an update on the sale of the land at Epsom Hospital, which I know you're very keen to hear about. So I'm not going to talk for very long, and in fact, I'm not going to talk for any more at the moment. I'm going to pass it over to Daniel, and he can take you through a presentation.
Well, actually, Trevor is going to take us through the presentation.
Right.
But here comes the first slide, and you'll see what the presentation is going to be about when it comes up on the screen. The first slide gives you a very big clue. When the projector comes on. Da, da, da. Oh, okay.
It's like Brexit.
It's like Brexit, isn't it? Some of you can see the screen already. Look.
Can you turn the lights off, Trevor?
Sorry?
Lights.
Lights off, yeah.
So there you go. So we're going to tell you about who we have sold it to and what we're going to do with the money. And Trevor, as our Director of Estates, is going to take you through a few slides.
Okay. Thank you, everyone. So, first of all, just wanted to recap on why we actually had such land and disposed of some of the land. So, we have a 2016-2021 estate strategy, and within that, it included looking at some rationalisation of the estate at Epsom Hospital. And I think our focus was very much about how can we improve the clinical environment and the capital investment required at Epsom to actually improve our clinical services. For people who aren't aware, that we did focus on the back part of our land where we have got predominantly support services, old buildings that were spread out, not providing maybe our inpatients or our core services. And it's approximately around 19% of the land that we had sold, and it's the back part of the site, and I'll show you a plan later on. And that, we know, will improve the efficiency of our hospital operations. It will improve, or it has improved the clinical environment, and we'll come on to them as well. So such as that outpatient function and our therapy services have all been relocated into improved facilities and more accessible. Shall I just go through this, Richard?
I
And
just
then
wanted to make sure all these slides will be available after the
I think we don't have an issue with them going on the Trust website. Okay. And then the other important thing is that we do have a significant backlog maintenance bill. That means that the stuff that we need to, in effect, bring our estate into a reasonable condition that we would all expect. That's significant backlog, but by actually the land that we disposed of, we've actually avoided having 13.5 million of investment needed to bring them up to a condition. And we also, what we've done is reduce our operating running costs, so things like the energy, electricity, maintenance of the building, cleaning, that. And although not easy to measure, we are actually reducing our carbon footprint. And obviously being in a healthcare organisation, that is something that we should be focusing on, because we know that if we can reduce the air pollution, we can improve health. So just some of the things around why we're getting on our buildings, and predominantly we're looking at our building, the biggest building being on the land that was sold is Rowan House. We had single glazed windows, we had water stains around there, we know we had a lot of work on concrete, rotten timber frames. Again, the network in Rowan House was very old, needed upgrading. We recently had an issue where we had a loss of the whole electrical power to Rowan House, and that's due to the ageing infrastructure and switchgear. We are having issues with water ingress in that building. We've only got one lift for the entire building. It's predominantly an admin focused building, certainly on the above the ground floor, and things like moving medical records. It's very manual handling intense and not ideal for modern. We don't have ideal fire escape routes, certainly don't meet current standards around fire safety. Mentioned about the windows. I think the other thing is that two floors of Rowan House was actually providing residential accommodation to our staff, which was really poor condition, and I'll show you a couple of them later on. It was cramped accommodation. We, in effect, we're trying to use it as an office facility, and it's an old nursing home, and we're trying to cramp people into an old bedroom. And, whoops. And with that, there's lack of showers. Just a few pictures in terms of some of the condition of the buildings and some of our rotten windows. This is some of our old plant and steam systems that need replacing. And this is some of the accommodation facilities where, poor ceilings, poor bedrooms and upgrades to kitchens, very outdated kitchen, bathroom facilities. So we've sold the land, and what we have done is secured over £15 million that we can reinvest back in to Epsom Hospital. And I'll just go through some of the things that sort of, this list is much more than 50 million, so we do have other capital that we're spending, but this is giving us an extra boost in terms of the stuff that we're doing now, have done, or proceeding. So we are about to reopen our first floor outpatients on Woodcote. We did have a problem with the lift. We're about in the next few weeks to reopen and open that up, reuse that again. We're currently completed replacing all our windows in Bradbury, so predominantly maternity services, but we've now extended that and it's on site now, the scaffolding to replace our windows in Denby's wing, and that's Swellyock and A&E. We've already moved a new therapy services from Rowan House and put that into Langley Wing, and that's much more closer to the patient cohort and easier access for our patients to get to on a day-to-day basis. We want to, and we know this building here certainly gets very hot in the summer. It has an old fouled ventilation system. We know we need to replace that, and we are planning that to be completed by summer 2020. So we know that we will still have summer 19 that will be uncomfortable for patients, and we're trying to look at some mitigation, but that will, this is a big project because there's a lot of asbestos work we've got to do. So that will come in 2020. We know lifts are a big problem for the trust as a whole, but certainly on the Epsom site, we are putting a lot of money into replacing our lifts. We've already replaced Bradbury. We're doing major upgrade works to the Wells Wing lifts in the coming months. And we're also putting in an additional lift to Langley Wing, because at the moment it's served by a single lift. If that fails, we can't move our patients around. We are also looking, as part of our thing, that providing a fit-for-purpose clinical admin building to the side of Langley Wing, and that will be much more open plan, modern office environment, fit for purpose. We have just started a scheme and signed a contract to actually replace our old boilers, and we're still using steam, which is not the energy efficient and the way we do things nowadays in terms of heating and hot water. So that's a project started. It will be won't be completed until 2020. It's a large scheme, but we're actually de-steaming the whole site, putting new boilers in, and actually we're putting a combined heat and power plant in as well that actually creates our own energy, in effect, to help us in terms of our savings. We've just started a massive replacement of all our light fittings in the hospital and replacing them to new modern LED. And you'll probably find as you walk around, a lot of areas are a lot brighter, and that's because we're putting the new fittings in. We also know that we do need to get a link over to Langley. We currently have to push our patients out to the outside elements to just get them through to our stroke ward, our rehabilitation ward over there, which is not ideal. Subject to planning, we're expecting that to be complete in 2021, and that will link into Wells Wing and be a great improvement for patients. We've already expanded our emergency department and urgent treatment care, allowing us to provide increased assessment and cubicle areas. And we also want to, this building, again, has got single glazed windows and the external fabric is in need of replacement and roofing. So we're looking at spending the money and actually refurbishing the external facade, and that will by 2022. Just then moving on to what, so we have sold the land to Legal & General, and they are looking at delivering on the land a well-class living facility at Epsom Hospital. And what they are very keen, and I'll go through their scheme, is very much having an open, they're not looking at a closed development that no one can access. They very much want this to be part of the hospital environment where staff and patients can walk in and use facilities and the public can come in. They want it to be very much a community provision. And as you can see, they're not looking at density in terms of how much can they squeeze on the site. There's an awful lot of green to the top left-hand side of green space, etc. On that. So they are looking, and this is subject to planning permission, looking at unique later living community for the over 65. So it's retirement, but actually one of the things that it does is adaptable. So you can, if you're in that age and you want to downsize your house, for instance, you can buy an apartment, and over the stages of life, as your needs change, the facility can be adapted, but equally they are putting in a very much 24/7 social care support as well. So it's all through the stages of retirement, and it can flex quite easily. So I think we're very clear that this is a real benefit in terms of residents of Epsom and wider in terms of social care things, and we believe that met our commitment of providing, for selling the land that actually gives some social care element into that. It's not going to be residential, just building residential, meeting housing target. It's very much focused on actually providing that social care element. It is going to be focused very much on a specific housing, but I think what attracts to L&G is actually it is next door to a hospital, and I think that they feel will be a lot of attraction because obviously the majority of our patients are of elderly population. So that actually improves it. But actually what they want to do is put, subject to planning permission, a lot of additional facilities in. So they are looking at a lot of community shared retail facility, a gym. There's very much a lifestyle centre that actually is more interaction for people. There will be, they're looking at restaurant in there. And also, something working with them is a nursery that will actually not only benefit residents around the area, but also potentially we've got a very much support in terms of helping our recruitment intention and our staffing who can use that. And if needs be, they've also they're looking at putting a number of intermediary step-down beds, one-bedroom facilities for the local population. And if there's a need at a later date, the NHS have the opportunity to look at using those facilities, which will actually help. I think it's important to note at this stage, and we haven't mentioned it already, that we have done a piece of work around the actual improving healthcare together, and we've already publicised that independent piece of work that actually says that we can actually build a new critical care building on this site at the front, and it's not we won't be impacted by selling this land off. I forgot to mention that earlier. So I think just importantly to mention on there that we believe that the approach that Legal & General have come across it, they certainly want to work with the hospital in about what benefits they can bring to the hospital, but they also want to bring in an improved facility that benefits the local community. So it's not just a block of residential facilities that is isolated.
That's it.
That's it. So that's a bit of a whistle-top tour, but I think we're open to questions now.
Yeah, thanks. So, do you want to come sit down and put the light back on?
So, actually, I'm slightly unclear as to what Legal & General are obliged to do on what, because there were things like, if needs be, we could do this. What have they? Do they have to provide the list that you've come out with, or is that just a wish list?
So in theory, we don't have a legal contract that says they have to provide X, Y, and Z. But what they are acutely aware is that we're their neighbours, and that actually, if they don't deliver on the schemes that we've in principle agreed on, that the trust will have the ability to object to the planning permission. And I think that would put a lot of weight into the decision. I think.
So can I ask then, what is the basic minimum that they have to provide before the trust objects?
So this is a commercial land sale, right? So we have not chosen the bidder who offered us the most money.
Understood.
Yeah, because we heard loud and clearly that there was a request that the land was used for a social care purpose.
How much of this, what percentage is required to be social care on this?
So there was no requirement for a percentage. There was a request from a very audible request from the population of Epsom to say, please find a buyer for the land that is not just pure residential housing. Legal & General gave us the best proposition for a purpose which both maximised the value of the land and was for social care.
So what percentage has to be social care?
So you can say the whole of this is for social care because they're saying this is a retirement elderly care.
That's not social care.
So it is everything from what they're going to offer, from your McCarthy and Stone kind of just
So what percentage has to be social care?
So it is everything from that to accommodation that requires where they can provide 24/7 nursing care. There is no definition of what is.
So you haven't actually addressed what the community, because there is no requirement for them to put in what is actually technically social care.
Well,
over 65s is not social care.
So there is no. You describe to me what you would think social care is.
You know what social. Don't play. You know what social care means. We know what applied social care is. What percentage in there has to be? Can it be 0% of social care? Because over 65 is not social care.
So I don't know what.
That's mere wealthy
I think we're having completely different conversations about what social care is. Social care in the UK is predominantly provided by the private sector, and it is support to people living in their houses.
So over 65s is not social care. I could go tomorrow, I'm getting close, and buy that. That's not social care.
So I think.
So you said quite clearly, Mr. Elkeles, that the public made it loud and clear that they didn't want that sold unless it was for social care. There's nothing in there that commits to any kind of social care.
So I think one of the things that we're not here to do is to sell Legal & General's proposal. That's not our remit. But what we have, what they are very clear on is that they're partnering with a specialist that provides this journey. So, let me carry that on. So, for instance, you may buy an apartment at 65 that you do not need any support whatsoever, and you're just independent. But through stages of life, you might need some dependency. You might need some social care support. That social care support is 24/7 on the site, providing for whoever needs it on the whole of the development.
By whom?
So this will be provided from the partners from Legal & General.
So it's private?
So, but everyone gets a personal budget. It's not about, so they can choose who they use. So
let's just be clear. Most people in this population, when you need support in your house, you pay for it yourself. What Legal & General have said, there are a small number.
This is just a housing development. They have access to everything that anybody else has. Living in sorry.
So there is a massive issue about how do you support older people in this country. As you know, there's a big debate going on, right? There are what Legal & General are bringing to the country, and this will be the second one only. There's one they've built one currently near Bristol. Is an elderly care community where people can retire and have all the needs that they have that they need until they die in a purpose-built set of accommodation. And Legal & General are looking to do this on a hospital site because clearly as people get older and more frail, they have more needs of interaction with the NHS. So the ability to, for us to support the people in that accommodation is much easier when the two things are together.
Okay,
And they've also said that should the NHS want to have access to some of the facilities for NHS patients, we can. So,
Could you address the question,
So,
please?
there you go.
we're not going to get an answer to that question quite clearly. So, when we go on to, for instance, is this like the really expensive end, McCarthy and Stone End, that nobody can actually afford to buy? Or is this a newer end where people can't afford to
Can
buy?
I just say something here? A friend of mine is possibly in one of these units you referred to, because he lives in Bristol. He has to pay, in addition to paying for his rooms, his
Maintenance.
one-bedroom flat, he has to pay £500 plus every month, just for the privilege of being there and using the facilities. So this is disappointing for us because it does not address the real social care issue, which is for people who cannot afford this very good accommodation, who cannot buy their way into this particular approach. So what I want to ask you is, how many residential units are we talking about here to start with?
So the issue about can people afford social care, that is not an issue for Epsom and Heller NHS Trust. That is an issue that you can resolve by electing politicians who want to put more money into social care. The way social care is currently provided in England is if the government are going to pay for it, it is means tested, right? So this is predominantly a development for people who are going to buy their accommodation. It was a commercial sale. The thing that is good about it is that the NHS has a need for some patients to step down into a convalescence facility. And as part of this, Legal & General are saying, should the NHS want to buy some of the accommodation that we are building, then the NHS is completely welcome to
And
use it.
how much would
Well, so we have-
price it?
So we haven't done that degree of negotiation yet, not least because Legal & General haven't yet got planning permission to build the accommodation. So I can't also answer how much accommodation will there be, because that will be subject to Legal & General with the planning team at Epsom
So
Council.
basically, it could all be private.
Yeah.
In fact.
It is all private.
It could all be.
It is all
and
private.
the NHS might not get a look at it
hospital
all.
land to an insurance company, and that alone rings bells. So you sold our NHS land, and you have no idea, having sold it, you've got no contract to got no idea of exactly what they're committed to do. Is that correct? You have no legal control over what they are going to produce for you. You've got no social housing in there.
So this is a commercial sale.
Yeah.
We believe, gone through a process where we selected a partner that is looking sympathetically on what the needs of the population are and looking at need. This is not just purely a residential development of how many houses can we get on a plot of land.
They are a commercial company.
And the piece of work that we have done in terms of our commitment and our legal protection is that there's certain boundaries and density that they can use before the trust can object about what they're doing. So we've got some principles set up.
The point is, you're trying to pretend that you didn't actually sell this land to the highest bidder. You actually were going to do something else. And actually,
We didn't.
right, you just sold it for the money. We
Can
all
you
know
tell us
that.
the
We're not
prices then?
stupid.
Yeah, could you
And I
tell us
think
how much you
they're trying to
actually
pretend that
made?
it's actually for something else.
Let's just be really clear, right? If we had sold this land to the highest bidder, we would have sold it to a housing developer who would have built tall, high-rise blocks of flats on the back of the
And so they might
site.
be low, but it's still
So-
the same thing.
No, it's not the same thing, right? So if we had sold it to the highest bidder,
What was the highest bid, please?
so that's commercially in confidence. It's much
No, this is mine.
so it was much higher than the value that Legal & General paid. Then we would have not honoured our commitment to sell the land for something that was for social care purposes.
It's not the social
Well, the
care.
difference. So, and had we
This grant rent that goes up every year in addition, and also some of these places. I mean, my aunt and uncle built a retirement property at Tadworth, and their ground rent went up every year. And unless you can afford to pay that, you're stuck. And as far as the 24/7 looking after them, they had to pay an extra extra money for that.
Okay, so let's just go back a few steps, right? The money that we're now going to spend on Epsom Hospital because we sold the land, right? We would not otherwise be able to spend on that
You
huge
should have had more, you just said, but you won't tell us how much.
on that huge list of essential critical infrastructure maintenance. If we can't maintain Epsom Hospital, then our ability to carry on providing services is significantly reduced because all of that spend is all on keeping the current Epsom Hospital going. And there's no other source of funding.
Ongoing maintenance and one-off sales of capital assets.
Well, that's another question that is not really for Epsom and St Helier, but actually for the government about how they choose to fund the NHS.
Can I just get this straight? Can I just get this straight? You didn't sell it to the highest bidder because you were observing the residents' assertion they wanted social care in there.
Correct.
Except there's no social care in there. So you didn't get the money and you're not providing the social care.
So,
I
so
don't get the
I
argument.
think that we looked at bids that what we believed supported our commitment to the public and supported, well, let me finish and I'll get there, and also supported the community. We had a number of bids that had complex solutions, such as they could give us a lot more money, but it was basically on planning permission, it was based on a lot of risks that we didn't foresee, we couldn't foresure than that. So we could have spent another 2 years trying to unlock more money, but there was no guarantee. So we looked at what we could do. I think it's really important that I know you've got a lot of questions, and it's a shame that Legal & General aren't ready to present what they're looking at their model, because there is a lot more in their model and the actual care that they provide in terms of
And can they
partnership.
change that next year if they so choose?
So, as again, it's all subject to planning permission.
And so you sold our land and on subject to planning permission over which you haven't got any control.
So we have control about density, height, and in terms of impacting on the hospital, but at the end of the day, you can't control entirely. I think that the key element is that Legal & General have to put a planning permission in. They have to meet the local planning development control plans, and they have to work with the planners in delivering something that meets the needs of the community within the planning regulations.
You said the trust could object. That you said subject to them doing A, B or C, the trust would object. What would the trust object to?
So there's certainly things like height, blocking our light, being close to our buildings, impacting on the hospital, the impact on the residents. So no, we don't have that commitment.
Can you please tell us how much did you actually get for this sale? Or was this commercially?
So it will go into the annual accounts. The contribution to investment in Epsom Hospital following the sale will be just over £15 million.
That's not answering the question.
Well, that's because there are some costs of the sale which you have to incur while you're doing the transaction. So, so we sold it for £18 million.
So it's going to be £3 million in costs.
Well, there are £3 million in the way that you then have to do valuations and all sorts of things that
And how
get
much are
taken
you
on.
getting from Naylor?
£0.
You're not getting anything from Naylor, which
Well-
promised to give you 2 for 1 on sale of NHS.
Oh, so Naylor said the NHS should sell its surplus land and use the proceeds to invest in estate in the NHS. Right? And that's
how
the,
much are you getting from
and that's the,
Naylor?
and if you remember, we've said this many times before. As a trust that has a very large deficit, we are supposed to use the proceeds of land sales to pay off our deficit and not use it to invest in the estate. We've made a pretty cogent case which says there's a massive investment needed in both Epsom and St Helier sites in the here and now, and we have been allowed to use the money both to pay off our deficit and then get the money back to spend on the critical infrastructure list that we've been showing you. So in a sense, it is 2 for 1. So.
But equally,
So how
on the
much did
Naylor
you get from
report,
Naylor?
so on the Naylor report, it was a recommendation. The 2 for 1 was a recommendation to the government that the government did not implement.
Yes, they did.
No, they didn't.
No, they did not. The government have not implemented the 2 for 1.
Even though Theresa May said she would.
Well, I don't know that.
She never
The
said-
other thing that
she
I have
never
is the
said
government
that.
have
So
not,
nobody's getting any
the
money.
government
Is
have
that
not
what you're saying?
supported that if you sell the land, that the government would double that amount of money.
So are you saying that no one is getting Naylor money?
So-
Let's be clear
Well,
here.
there never was any Naylor money. He wrote a report which had
Right.
some
So
recommendations
no
to the
one's
government.
had any Naylor funding?
There is none.
There is none. Okay, we'll check on that.
Sorry, may I just clarify something? I think a lot of this discussion actually is premature because planning has not been granted
Yes.
and we're wasting our time speculating. It's very much a question of what the planning department come up with in relation to affordable housing,
Yeah.
non-affordable and social housing. Having said that, is this sale conditional on getting planning? It's not. But in which case you're to be congratulated because you've actually got significant inflow towards what's needed to maintain the building here.
Yeah.
So how
And
much
that
do
I
you sell next
congratulate you
year?
on. Thank you.
So what do you sell next year for the running costs and maintenance?
Well,
When has we got zero hospital and all luxury retirement homes?
So the planning rules that came out for the NHS for the year 1920 said no trust can sell land to use to achieve their financial plans for next year. So as it currently stands, we have no plans to sell any more surplus land
They
because
said you couldn't use it for last year either.
no, they didn't. The way we achieved our financial plan for the year 1819 was selling this plot of land. That was a core component of it, and if we had not sold it by the end of March, we would not achieve our financial plan, and we would lose a lot of money as a result. Because in order, the way the money works, if you're a deficit trust, as we are, if you don't achieve your control total, you don't get access to lots of non-recurrent money, and the non-recurrent money is what you need to keep on going, and we don't want to find ourselves like Kings, who have the most extraordinary amount of deficit and end up with very big loans at a high interest rate to keep
And you
going.
don't think that this is all a deliberate plot to make you sell off our NHS and ruin it? And you're part of that process, Mr. Elkins.
It's not, as I just said to you, the rules for 1920 say hospitals can't sell surplus land to prop up their financial position.
No, but they can sell it for maintenance, presumably. And you are using a lot of the money you've got for basic maintenance that hasn't been done for 30 years because you yourself said you didn't know what your long-term plan was, so you didn't think there was any point in maintaining the infrastructure.
No, that's completely not true. We said that we haven't had access to capital because there hasn't been a strategy for Epsom and St Helier, and look what has happened to the buildings. What we have spent the last few years doing is demonstrating the case that says, actually, do you know what? We are a hospital that would rather like to provide healthcare to our local populations, and we do need some buildings that are safe to do it in, and we have secured the biggest investment that this trust has ever had in sorting out its buildings. So we're coming to the end of year 2 of a 3-year plan to spend £100 million, making your hospital buildings much better places to be treated in than they were. So you can have all sorts of questions about the legitimacy of the appropriateness of where do you think of how we have sourced the money. But I tell you, if we hadn't sourced the money, you would not be having as good hospitals locally as you are in the process of
You just said
getting.
you need non-recurrent money to keep going. How do you keep going if the money doesn't recur? You're talking nonsense and you're not answering any of the questions.
Right, sorry, I've been quiet because I got told off last time I shouted out, so I'll put my hand up. First of all, thank you for the presentation and explaining what's going on there and letting us know. In one of your replies, you said in partnership. Does that mean with the sale of the land in partnership, the trust will be getting money from Legal and General on rent and stuff like that?
No.
So what was the partnership?
So I think it's very much about working as neighbours and how can they support the hospital, how can we support them. So some of the things that we're exploring, such as the nursery, that would be a great benefit for our staff, that they'd have a nursery on site and then working here. So that's something we want to work
It's
with them
on
on.
site, isn't it?
Well, it's literally just,
But
and
so
then
the social care element has been, actually, when you're old, you haven't got so far to travel to the hospital.
No. So as we mentioned, that there will be there'll be 24/7 social care support in this facility, and there'll also be there's this wellness centre, and they do a lot of rehabilitation and health.
But we've got that in Epsom now with number of gyms, number of retirement homes, number of retail units. basically just moving it nearer so you're nearer
So-
the
so I
hospital
think
you need to go.
it's-
Because you've sold the land, so it's not your land anymore. It is a personal development, private development.
That's correct.
What I
But-
don't understand is, don't get me wrong, I totally understand you have to sell this, you know, you have to do something, and I understand that. But I don't understand is, given the strength of feeling that we, you know, I've sat in on these meetings, I've seen the strength of me, and I believe my mailbox is full of this stuff. And all I don't understand is how you could not have decided to sell the land with distinct caveats that led towards what we were talking about and that what we asked. You sell the land, but if the buyer has to honour this, and this.
So the first,
But what we've actually got is
Yeah.
you've described, or any Mark McCarthy and decent
No.
McCarthy and Stone, something my mum would want to go to. You know, it's not. If you've got the money, it's social care.
So-
and
so the
there's no
process-
social housing as far as I can see, no affordable, and it hasn't addressed the social care issue.
so the process that we went through to sell the land, right? The first step in the process is asking any other part of the public sector, would they like to buy the land? And so if Surrey County Council, who buys social care for the residents of Surrey, had wanted to buy the land for a social care purpose, they could have done. In the same way, a university could have done it, or a...
There are public-private
but-
sort of,
so-
when you
but-
sell the
but
land,
we-
you have to give a public
No,
service.
so we received no bids that passed any the hurdles that we set up about, for example, could you actually complete the land sale this financial year, from any public sector organisation. So having not got any public sector interest in the land, the next thing you do is you put it on the open market, right? We wrote a brief which says we really don't want to sell the land to housing developers. We want to sell the land for someone who is going to do something for a social care purpose. Had we sold it to one of the big house builders who expressed an interest, we wouldn't have got £18.5 million. One of the bids we got was for almost £40 million, right? And we decided...
Then I don't understand that. If you haven't fulfilled the brief for social care,
But we have
then
fulfilled.
presumably you should have gone for the money.
So we have fulfilled the brief for social care, because most social care in this country is provided by the private sector. It is not provided by the state. Okay? So and that is just a fact about how social care accommodation is provided. And in this development, we're going to provide something pretty amazing for older people or the Legal and General, for older people in the borough.
Do that. Most of that stuff that you read out, you said if they want to, if they feel like it, there's no guarantee that even that's going to happen, because you said in this list, you've used the words like if they deem it necessary, if they do this, if they do that. Apart from the building for over 65s, all the other things, they're not committed to.
So I think their model it is very clear, and I think we're going to have to wait for them to undertake their public consultation and briefing around what they're looking at. But they're partnering with an organisation that focuses very much on health and well-being and social provision to that cohort of residents. So, yes, we've got no legal obligation to hold them to account, and equally, they can't say we will definitely do X, Y, and Z, because everything is subject to planning permission. They have got to work with the planning and work out the needs of the planning department, the local population, in terms of car parking, access, height, and all of that. All needs a bit of work. So no one could lock down this is what we're going to do, and I'm holding you to a contract. So they can change that.
So you might as well have sold it for 40.
But so I don't believe they are going to change their plan to be...
We'll rely on that then, won't we?
So
we can't even rely on you to do what you said you'd do.
So-
So now you're telling us to rely on people who sold the land.
So I don't believe that they're going to go away from the model that they are offering here and they propose to us. Yes, I don't have a legal contract that states that, but I think Legal and General do have a large reputation that they are very protective over, and they...
So did the NHS. And look what's happened to that.
And I think that they very see this as a flagship opportunity, and they very much, from the conversations I've had with them, want to commit and to be part of the community. And I think we need to leave that in terms of Legal and General now, once they're ready to actually communicate with the public and do some briefings about what that looks like.
Can I ask how many units that you're going to buy?
Okay, sorry, can we turn the lady?
Thank you. One of the things I think that people were concerned about originally was that if the land was sold, it reduced the size of the hospital. And they were concerned that the A&E department the hospital would be downgraded, and there would no longer be an A&E department, which would mean a lot further travelling, obviously. And I just wondered if you could say whether there's any plans to keep A&E open indefinitely, or any plans to downgrade the hospital.
So if you remember, one of the tests we were set was, in any eventuality for the future of Epsom Hospital, if you sold the land, would you be able to meet any eventuality for Epsom, the future of Epsom Hospital? And so we did a piece of work as the trust where we said yes, and then our commissioners, the CCGs, did a separate piece of work through an external set of consultants to say, do we believe what Epsom and Helier have said is true? And the external report that they produced, we have put on our website, which says, yes, that is true. So what are the scenarios for the future of Epsom Hospital? So probably you know that there's a programme called Improving Healthcare Together, which is being led by the 3 clinical commissioning groups who commission our services, so Merton, Sutton and Surrey Downs, about what do we do with Epsom and St Helier? Because we have said as a trust that we don't think we can carry on as we are in perpetuity, because we don't have sufficient workforce to deliver the 24/7 quality standards in acute services. We don't have buildings that are fit for purpose for 21st century healthcare, and we've got a whopping great deficit. And we have said we would like to consolidate our acute services, so 6 services for when you're sick, onto 1 site rather than 2. The CCGs took our work and said, do we agree that that is the right model for the future? And they have done a piece of work and they've engaged the public and they have said yes. So now we submitted something called a pre-consultation business case to the higher up parts of the NHS to say...
Who's we, sorry?
The CCGs.
Oh, so that's not you? That's
No, so Merton, Sutton...
That's not we, they.
Okay, well, we, the NHS, submitted a case to the regulators to say, will you now let the 3 CCGs and Epsom Helier go and consult the public on which is the best of the 3 sites to put...
So no choice of keeping all?
So with the 13.5 million that you've got, you're still going to consolidate that into one hospital?
Yes.
Because that's why I'm here, to find out what you
So hang on, let's just finish the first question, right? Consult the public on which of the 3 hospital sites that we have is best to put the consolidated set of 6 acute services. And depending on which site you choose, you need between 400 and 500 beds. And we demonstrated to all the work that was done affirmed that you would, if the chosen site was Epsom, you would build the building at the front of the hospital, so from the Dorking Road onto Headley Wing and adjoining this wing and the Bradbury Wing. That's where you would put it. It would fit, it would achieve planning permission, so we did a piece of work with the council about heights to make sure that the massing would be okay, and you would actually be able to build it. And therefore, if we sell the land at the back of the site, you are not compromising the ability for Epsom Hospital to be the site of the consolidated acute services, should that be the preferred outcome that the commissioners wish to consult the public on.
But she asked about the A&E. All A&E services, anybody requiring any kind of A&E could get it here, yes or no?
So in the model that we want to consult the public on, the major part of A&E is one of the 6 services that needs to be consolidated. So in the model, urgent care, which is what 100,000 people come to Epsom and Helier for every year, predominantly delivered by nurses and GPs, remains on both sites. If you are very sick, in the model, rather than running 2 major A&Es, the model says have 1. And the reason for that is so we can staff it safely.
The reason for that is STP, and we both know that.
So if you look at, just take this week, right? We have had an extraordinarily busy set of nights this week at both Epsom and St Helier. we only have the staffing for a skeleton amount of staff at night, and it means that you get very long waiting times and people are not getting cared for in the way we would like to do it. If we can consolidate our workforce for the sick people onto one site, we will deliver much better outcomes, much better waiting times for
For the
people.
ones that don't die waiting for an ambulance, 'cause it's so far away.
So that is the model. Do you want to say something
Hang on,
about
can
the
I
model?
just say something here?
And then I will answer your question here.
We have got government housing targets in all the areas surrounding Merton and Sutton and here, which will be hundreds of thousands of more people. I know, because I'm on the right committee, we are having absolutely not 1 centimetre more road network than we have now. We've got an ageing population, particularly in Epsom. We are disproportionately leading that way. And
it good?
Roads, I mean, the roads are gridlocked now.
Yeah, so isn't it good that we've just delivered for you half of your annual housing
We haven't
target?
had a housing target
for-
built yet. The houses haven't been built yet.
No, this development delivers half of your annual housing target for a year for older people on a site that is not going to cause you lots of congestion.
It's not half our annual fee for a year. No, it certainly isn't.
How many units are we talking about here?
Your housing target is 400 and something, and this is 200 if they depend.
No, we're talking about the government housing targets of 6,000 or what to 7,000 houses in Epsom.
Over many years, not in 1 year.
Well, presumably the hospital, these people are going to require hospitalisation.
You talk about the number of staff that you haven't got, and reducing acute facilities to one site will enable you to staff it properly. In your own publication, you say that you currently employ, for instance, 26 obstetricians, and you are going to have in your single site just between 12 and 16. That's not improving staff cover, that's practically halving it. And the same is true in paediatrics. You currently have, it says in your document, 26 paediatric doctors. And in your new plan, you will have between 12 and 16. That's not improving anything, that's halving it. The same as you plan to halve the number of acute centres. People are going to die because of your actions, and I think you all ought to be ashamed of yourselves.
I think they all ought to be.
So,
And
Sandra,
actually, you said that you didn't say about the backlog. I've got here in print, quote from you, there was certainly uncertainty over whether both the hospitals were going to stay. So there was no point investing money in either of them. You said that, not me.
so if I can just come in, Sandra, I sit here as a paediatrician, I sit here as a medical director, and I sit here as a board member responsible and accountable for clinical quality. I can absolutely give you assurance that we would not be progressing any discussions about a model that compromises patient care. It's quite the contrary. I think in terms of specifics, which I'm happy to go into offline, the reason you've, well, I don't think it's a helpful conversation to have here, but the specific around paediatrics, sorry?
You don't think it'd be helpful to who?
Sorry, the specific point about paediatrics is because actually what you'll be getting with a consolidated model is a separate rota for paediatrics and neonates.
Right. But you say here in your document that you currently employ 26 paediatricians.
Absolutely.
And if
So,
a single site, you would only employ between 12 and 14.
no, it doesn't say that. So,
It does say that.
okay.
It does
not say that.
So, Sandra, what I can give you absolute assurance in relation to is that
Does it say that or doesn't?
okay, is that there will be a total of 26 trained paediatricians, half of whom will contribute to a paediatric rota and half of whom to a neonatal rota.
But you now have 26 in each of those.
No, we don't.
Well,
No.
your document says you does. Does it say that or not?
So
The document you're looking at
yeah.
says, it says, how many consultants do we currently have in paediatrics?
Yeah.
26.
Yeah.
And then it says, if you were only going to operate services on one site, you would need a minimum of 12 to 16. That does not then say, we're going to not have 26 consultants. What that table was trying to show is that in some of the specialties,
It doesn't say you're increasing them anywhere.
the minimum number of doctors that you need is way more than the number of doctors we actually have.
You haven't listed them.
So,
You've listed that you might need 2 more in intensive care and 1 more in acute medicine. No,
Right, I think we, yeah, no, can we answer the lady at the back's question.
I've changed my question. So I guess my concern here is having 2 children in the area and they've had quite a few issues and I've had to come to A&E here. And I'm guessing over the other circle, St Helier as well, it's the speed in which you can get to your A&E if there's an emergency. So if you're going to consolidate it, obviously that time to get to the A&E is going to go up, and that's people's concern. Well, it's my concern anyway, having children that are being sick. So, you know, it's not going to help me in that, is it? I mean, I just think that's why people are, you know,
So,
time to get there.
yeah, so what I'd say is 85% of the time, when children present, they could be managed in an urgent treatment centre, which is what we'll have on all sites. So that's the first point to make. What is actually very evident as a paediatrician is that what we need to have on site in an acute paediatric unit is high dependency unit support, which we don't currently have for when children are really sick. And this model allows us to do that in a way we don't at the moment.
So you will have that at both sides?
No.
Right. So
No.
you've still got that
So what we'll have on all sites is the ability to stabilise and initiate treatment, and then transfer appropriately to a unit with high dependency support, which we don't have at the moment. So that's an enhancement in the care and quality.
Right. So you won't have an A&E, you'll just have stabilising.
No, we will have an urgent treatment centre.
Which is not going to happen.
So just go back to your previous question, which is the money that we're spending from this land sale is on the buildings that we want to keep on the Epsom site in perpetuity, right? The point about this was to say, which buildings do we need to get to be fit for purpose, because in every eventuality we're going to need to use them, and spend the money on sorting out the critical infrastructure maintenance in those buildings. Don't spend money on buildings that you're not going to want to need. So that was your first question. And in answer to your second question, let's just be really clear that so most parents, when they bring their children to hospital, it is actually for quite a minor thing, and then in the urgent treatment centre, they'll be able to deal with it. If it's not a minor thing and is a major thing, the staff in the urgent treatment centre will be able to make the child safe enough to travel to the main centre. And when you go to the main centre and it is properly consultant staffed, your chances of having a good outcome for your child will be much higher. Ambulance journey times in our catchment, if you dial 999, so it'll take a number of minutes for the ambulance to come to you, for which there is a standard and mostly CCAM meet it. Once they have picked you up and they take you to a hospital, the average ambulance journey time in our catchment today is 10 minutes.
That is, sorry,
No.
I really
Right,
have to
if
go.
the
I've spoken to your paramedics.
The average journey time
That's an
is...
average time at the least busy time of the day. That is average for one particular lowest time of the day.
So it's not actually.
If you go
But-
for, now I've checked these figures, so if you go for rush hour, midday or in the mornings, it is even your figures, which you actually did give to somebody I know.
Well, they're all in the public domain
No,
because the
but
CCG published
the
them.
written figures
Yeah.
are not what the paramedics experience. They think it's laughable. And that is with a flashing light on the top.
So-
For you and I, for the average mortal who has to queue up like everybody else, in 5 years' time,
So-
but, I really have to finish. In 5 years' time, going up to when those housing targets are done, so that every area has at least 6,000 to 7,000 more houses, which is in 4 people per house, if you average it out, over the whole of that area, over the second busiest road network in the country, after London. Surrey, I'm on that committee, Surrey's roads are the second busiest. We are worried about the absolute gridlock, that even the first phase of housing is going to be built. That has not been, nobody has ever, in your conversations I've had with any of you, acknowledged that key fact. You're waiting to answer me, and yet nobody, I guarantee you will not say, we have done the figures on that. What you will tell me is, we've got the CCGs or whatever it is, are doing an analysis of the ambulance journeys. You are not doing an analysis of the public journeys. And if you are, you're keeping that figure very quiet, because I've asked for it time and time again. When this, Councillor Baker here knows we'll be able to give you the figures for Epsom. I can give you the figures for the rest of the area.
So we have done that analysis, and also, I know you are a county councillor. Perhaps you should be arguing as the county council to improve the road network so that it's easier to...
Well, improve the hospital service.
So it is...
We don't have the ability to do the network. There's
So,
nowhere to do the
the-
network.
anyway,
You know that.
what I was going to say about the average ambulance journey times, right, is that wherever you move the 6 acute services to in the catchment,
Don't move them.
the average ambulance journey time does not increase by more than 3 minutes. And we have done that analysis,
So I guess
both
it's
using...
Is it been decided that you are going to consolidate? Has it been done?
No, so we are waiting for permission to be able to consult the public on which site. And the thing we are waiting for in getting the permission... Well, so the thing we're waiting for is the local NHS, so the CCGs as the statutory bodies who do the consultation, but we're pretty keen on this too, you know, is because what will come by enabling us to go and consult is to unlock £500 million to build a new acute facility for you to be treated in if you are, you or your family become very unwell.
So
Because
why
what
is
you
there
all have to
money
realise,
spent on the current ones?
what you all have to realise is, if we don't get the ability to consult on building a new acute facility, our ability to carry on running Epsom and St Helier hospitals as they are now is not very high, because it is massively fragile, mostly because of the staffing, and there will come a point where we can't cox and box this anymore to keep both things going. How long does the what last?
13.5 million. How long will that last?
But I don't know what the 13.5 is. The money from this, but that's 15, not 13, is in the here and now. We're going to spend it in the next 2 years to sort out the current buildings so that they can be safe. That's what the money's been spent on.
Do you think that will actually help the process of perhaps having an A&E here, because the buildings will be better, maintained, and it'll just be more about, because if the building is maintained, the buildings that we've got now, and it just means having £1 billion, £500 million put in because it's worth it, because we've already got a very nice site. Do you feel that will help?
So certainly the capital costs of doing the build on the Epsom site are lower than the other two, in part because the quality of the buildings is better, right? But that is one dimension. But the list of criteria that the CCGs will use to make their preference is like this long. But that is one of them.
But aren't we the equivalent? I mean, basically in Epsom, we're the equivalent of living in London. I mean, just it's an artificial border because of we are the most urban, smallest but most urban borough in the whole of Surrey. Yet I understand from figures that I asked for that our population will be the furthest away from an A&E than any resident of London. We will be the furthest away from an A&E in Epsom, from anywhere in Greater London.
Well, that depends on where the CCGs choose the site. So if they chose the site in Epsom, then clearly that would...
they're not.
Well, they haven't made a choice, and if they chose it in Epsom, that wouldn't be true. And if they chose the Sutton site, that wouldn't be true. So literally, the Sutton site is about 300 metres from the borough of Epsom. And if they chose it at St Helier, it may be true. All you have to do is walk out of Sutton and go down to Northey Avenue, and you're in the borough of Epsom and Ewell. It's pretty close.
You said Epsom, not Ewell.
Well, the borough that is called Epsom and Ewell.
Yeah, but I'm talking about the residents of this side will be the furthest away from an A&E for any person, a resident of London.
I think what's important is to actually look at the distance away from a safe place where they can get acute, immediate health care. And I don't believe that this proposal will increase that distance at all. It will do quite the converse.
So if you had a baby in Epsom that needed transferring for an urgent care, if there was no A&E, would there be any means of putting that baby safe or for the journey into a medical coma? Would you have anyone there that could do that if you removed all the A&E and the maternity?
We're very clear of the need for staff on all sites to have the core competencies to begin intensive care.
So you could put a baby into a coma, even though you've got no acute services there, you'd have those staff. So you said your GPs and nurses would be doing the urgent care.
So Sandra, the initial stabilisation isn't putting a baby in a coma, it's actually securing the airway, which staff would be able to do.
Personal experience of a baby having to be put into an induced coma to move from one hospital to another. If you came across a baby in Epsom, say, or in St Helier, if the position were reversed, would any of those GPs and nurses be able to put a baby into a coma for journey?
Just to explain, they'd be able to secure the airway, and the neonatal transport team would come and do the transport safely.
Well, that's no different to now, right?
Well, it is a little bit different because at the moment you've got acute services on 2 hospital sites.
The assurance is the initial care and stabilisation would be safe.
So I'd take that assurance, even though you wouldn't have the staff there to do it.
And Epsom is only
Right.
delivers low risk
I'm
babies
going to
now.
take Dave's point and then we're going to move on to the other items.
Daniel, a while ago you said in passing that you don't want to spend money on buildings you're not going to need. You have also recently announced the expansion of A&E facilities at both Epsom and St Helier. I would like to hear how much you've spent on the expansion of both those facilities, given that you are not going to want one or both of them. I want to know how long they're going to continue to operate as full independent A&Es on 2 sites. What was the bill, and how does that square with your remark about not spending money on buildings you reckon you're not going to need?
So I think, first of all, I think we slightly changed the language there. What we said is that we're focusing the money, the investment we're doing, our capital investment, on buildings that we know will be retained on whatever option is chosen for the future. So it's not about we're not investing in buildings that aren't required. What we're doing is making sure what little capital we have and what we are getting.
Sorry, I didn't ask that. I asked how much have you spent expanding to and how long will they operate after 2020?
So we spent, in the last year, almost £3 million on both the A&E departments expanding in total, right? And do you know what a big benefit that is to the patients who are currently...
How long after 2020 will they remain for A&E?
So the money we have spent is being used now in facilities that are treating patients better. The benefit to the population of Epsom and St Helier by us expanding our A&Es now has been that we have...
How long will they continue?
I will
answer the questions put.
Well, let me just explain to you why it's a good thing to spend money on your A&Es now. Last year, we had really quite long ambulance handover delays because the number of people needing to use our A&E and the size of both the A&Es was too small. We have made both the A&Es bigger, and we have reduced our ambulance handover delays, and you can see it in the performance report, if we ever get to it, by somewhere between 1/3 and 1/2. So that is meaning that the ambulance services are finding it much easier to be responsive to go to people's homes when they dial 999. That is a good thing. Our aspiration is to keep both the A&Es running as they currently are, ideally until we get to being able to build a single acute site.
You have still not answered the question. How many years after 2020 will both those A&Es be performing as full acute A&Es with all the necessary services and ancillary services behind them? How many years?
So the honest answer is, I don't think we can answer it today.
The honest answer is you're not going to answer.
Well, and the reason why we can't answer it is because as we have been trying to signal for several years, our ability to keep on running Epsom and St Helier as they are is getting harder and harder because the workforce issues are huge, the building issues are huge, and the deficit issues are huge. The thing that is most prominent about what we are grappling with, and if you read our risk register, you will see it, is having sufficient workforce to provide the services 24/7. So in the ideal world, you help us secure the money from the government to build a new acute facility so we can get on and consult with you about the right place to put it, and we build it as quickly as...
We want 2 acute hospitals, we don't want it half.
So you might want that, right? And I think...
and you're not going to give it.
And as it currently stands, you can't have that in perpetuity because There are simply not enough staff to provide all of the standards 24/7.
If you haven't got the staff.
Well, because in the here and now, right, both our departments were too small, and we were causing other parts of the NHS problems. We have solved the problem, so you should be.
No, you
It is
haven't. If you haven't got the staff, you haven't solved the problem.
We solved a part of the problem, and so it was worth spending the money so you have better A&E. So if you're telling me you would have preferred us to not spend money improving A&E, then that would be very odd.
But anyway, Daniel, I attend your 15 Steps Challenge pantomime that you use to limit the time for questions every time you have a trust board meeting. And on one of those occasions, I don't know if you hadn't briefed your then board member properly, but he came in with a report that he'd been in A&E that morning and they were having problems. They were unable to hand over from ambulances patients who'd been transferred from St George's who couldn't cope, and the reason you were having problems was because A&E was congested, and the reason that A&E was congested is because you don't have enough beds. And your plan is to reduce the number of beds by at least a third. How does that make sense?
This is going to be the last answer. The plan has the same number of beds. In fact, it has a few more beds in it. It does. The document that we have submitted to our regulators, the pre-consultation business case, maintains the number of beds. In fact, has a few more beds in the future than it does now.
You keep saying
Right, I'm going to pause all this now because we've had a really good discussion. We could go on all day, but actually we will just continue to have the same debate. I'll just say two things. Firstly, on the Legal and General proposal, clearly, Legal and General in short order will be publicising what they propose in a lot of detail, and then obviously they will have to apply for planning and all of those things, and therefore the debate will move to the debate at Epsom and Newell Borough Council, and hopefully we'll get to a really good outcome which will benefit everybody in Epsom. On the question of the future of our hospitals, we've had a good conversation on that. The next steps on that is for the CCGs and the Department of Health and NHSI and NHSE to agree that we can go out to public consultation, at which point everybody will be able to have as a huge opportunity to state their views. There will be meetings, there'll be surveys, there'll be online, there'll be all.
Saying that one of the options would be to keep both, and you're saying
No,
that the options
we've never said.
include that. Who's telling the truth here? You're saying
The base case is always.
that there
base
will
case
be
is
an
always.
option to keep
but it's
both
not.
sides. You're saying there won't be, and yet you're saying we.
So the work the CCG done has said the benefits of each of the consolidation sites to the base case, which is keep both. The problem is the base case isn't actually deliverable, because if the base case was deliverable, we wouldn't have to go through all this effort to demonstrate to everybody that moving to a single site was better, because it would be much easier to say, do you know what, we can find the staff to carry on providing the 6 acute services on both sites.
You've got to shut 1 or 2 of our big hospitals.
But they've
and
said-
that's exactly what you're doing.
But they've said that because we have said as a provider, this is not sustainable.
No, they've said that all around the country. They've said that you've got to cut the number of acute A&Es, and in this area you plan to shut 1 or 2. And that's exactly what you're doing. However you dress it up, you're following the STP, cut £1 billion from NHS spending in South West London and Epsom. And that's exactly what you're doing. And the rest is just wallpaper.
And you're spending millions.
Instead of building that massive new consolidated whatever, why don't we put that money into training up staff?
Yeah.
Why don't we do that? Why don't we use that money?
Well, because
The money to train staff is revenue, and then you have to pay all their salaries all the way going forward, right? That's one set of the NHS budget. That doesn't help you sort out your buildings, which is a capital budget, which is different. And you've got to.
You can build brand new buildings, and you put it into training new staff, having more
Yeah,
staff.
but you've got to solve both the building problem and the staffing problem. It's not like solve one or the other.
You just fixed A&E. You've just fixed A&E here, so it's all working lovely. The building's fine. So
If it's helpful, I'm very happy to have an offline discussion about the staffing
Yeah,
issues,
sure,
which
well,
I've
so
done
don't
with some
listen to
others.
your excuses and lies.
Right, thank you very much. We are going to move on to the next part. And
Just a minute.
no, hang on, David. We've had a big discussion this morning.
How much did you spend on the Deloitte study, on the engagement that you ran? How much is being spent on improving healthcare together? This is all money that should have been spent on maintaining a proper health service at 2 hospitals.
All of that has been published by the CCGs on their website.
Effort.
Right, we're going to move on. And although I understand that you're not particularly, you think it's a bit of a far, we don't. We're going to have a 15 steps report back because we think it's really important that we hear about what is going on from our unannounced visits to various parts of the hospital. So I would like to invite, who went? So,
Where did Martin go?
yeah, where did Martin go? Martin.
To maternity.
Right, Martin, thank you.
That's
That's all right. Thank you for coming.
Okay, so we went to maternity. I'd say of all the 15 steps that I've done, this was probably the most impressive in terms of relatively few facilities, estates issues and relatively few staffing issues. The atmosphere was calm, it was clearly very clean, it was well organised, and in particular, the matron who took us around had clearly made a huge difference in the time that she'd been there. And we often talk about how important it is about the way that you treat people and about leadership, and good people often attract other good people. And I thought it was really telling that actually, if you go back, there were significant staff shortages and vacancies. And one of the things that she managed to do through her own efforts largely was to actually solve that and attract more staff. There were some specific things that we noticed needed improvement. Some of the hand sanitizers were empty. There was a bit of an issue around some of the patient notes being on display, or at least open in rooms, although the whole area itself is very security controlled. But I guess the other side of that is the reason why those were open and not in locked rooms is because the heat is such that, because it isn't air conditioned, the heat is such that it makes it very difficult for staff to work in those conditions. And actually, for some of the medicines, it's otherwise too high for them to be stored safely. So it's probably a good example of, obviously, the benefits of actually having air conditioning, which clearly we don't. But did you want to add anything, Debbie?
No, I mean, I think absolutely very positive. A very positive visit. I'd echo all of your comments. Very welcoming team. Just in terms of infection prevention and control, everybody was seen to be bare below the elbows, so that was very positive. Yeah, a really very positive visit, I would say, acknowledging the points that you've raised that need to be addressed, but clearly the matron was picking those up as we went round.
Right, let's Chris, where did you?
Oh, sorry, I was late. I wasn't able
Oh,
to.
you didn't? All right. So I've got James, and I've got Peter. Who would like to go next? James, thank you.
So I went to the emergency department. I went in through the waiting area, which had about 4 or 5 people waiting. It is a quieter time of the day, but it was quite a welcoming environment. The receptionists were smiling. I spoke to a couple of patients who had all been triaged apart from one, and one person, the person who hadn't been triaged, had been in the department for 4 minutes. And they seemed to understand what the process would be and who they were waiting to see. I then went to have a conversation with the triage nurses and one of the GPs from the urgent treatment centre. They did articulate that they were concerned that their staffing levels were low. They did feel that their morale was low because of their staffing levels, and that they couldn't always keep on top of the workload that was expected of them. The GP I saw was a little bit frustrated in that she felt she hadn't been able to access all of her training requirements, so I'll pick that up, and she wasn't sure who her line management route was. So that surprised me, but I'll certainly pick that up.
Was she one of our employees?
Yeah, she is employed by the trust. She'd worked at a different urgent treatment centre that was standalone, and I think she felt there was a little bit of a tension between how we manage an urgent treatment centre that's co-located with an emergency department. I then walked through, I followed the green dots through to the A&E in the same way that patients would do from the waiting area, and went to spend most of my time in the hub and the ambulatory care unit. So the hub is an area where patients who have been through the system in A&E who need a more detailed medical assessment, or some patients where the GP has directly referred for an assessment, are waiting. It was a very pleasant environment. We used to locate this area on one of the medical wards, and the environment that they've moved to is far better. It was calm, it was airy. I spoke to one of the patients there, and her daughter. They were waiting for a detailed physiotherapy assessment, and they felt happy with the care. I really sensed that there was good teamwork and flexibility among the staff, because in the two areas, the hub is more medically led by the medical team, and the ambulatory care unit is slightly more planned and is run by a different team, but there's clearly a cohesion and flexibility among the staff to cross-cover each other. I had a conversation with a patient who had been referred up through the GP services. He'd had a fever for many days, and he was full of praise for the team. I did have a conversation with one of our new advanced nurse practitioners in the ambulatory care unit. She'd worked at another trust before, and she thought it was a very welcoming place to come to, but we are preparing for a CQC visit, and she said while she saw our practices in some key areas were very good, she didn't think all staff were as attuned as they might be to some aspects of care, such as the need for ideal infection control practices, the security of medical notes, and an awareness about how we look after some of our more vulnerable patients if we need to restrict them. So this is a technical term called deprivation of liberty. She said she'd seen good practice, but she thought that staff weren't fully prepared for a CQC visit if inspectors arrived today and could answer questions appropriately. So all in all, I sensed it was a positive visit, but staffing levels were clearly a cause of concern for some members of staff.
Thank you, James. Staffing levels is obviously been a theme. Any staffing levels has been a theme throughout the day. Peter?
So I went to the acute medical unit this morning. When I arrived, it was very welcoming. Both the nursing staff and the ward clerks were attentive to both having a discussion with me about what they were doing, as well as being anxious to ensure that they were able to get back to monitoring their patients. So it was clearly busy, but not over busy. There were a number of patients who were being discharged, others arriving. The sense of calm and efficiency was strong. The staff spoke positively, particularly new joiners. They said they'd felt very welcomed and supported and valued. So that was all positive, as well as those who'd been there for some time. The two areas where I think there was some need for improvement was, I suppose, the busyness of the acute medical unit is by its nature means that it's important that patients know who's their named nurse, who's their named doctor, and why are they there and what's going to happen to them next. And I think sometimes that busyness gets in the way of making sure that people know why they're there and what's going to happen next and who's the person they can immediately turn to. So that was the component that struck me as need for some improvement, and I fed that back because that element of communication is clearly important, both for staff so they know how they work as a team, but also for patients to know what's next for them. And one patient I spoke to didn't really understand why she was there waiting for more tests, although she clearly did understand that, but it took some time to probe that through because of her, basically she had a risk of falls because of low blood pressure and anemia. So she sort of understood, but wasn't really feeling that she got the interaction with the doctor to properly work through why she was there. So the communication was one element. But overall, for a busy area, it was, as I say, calm and efficient, and people spoke positively of the visibility of your senior nursing leadership and some of the changes that have been put in place there, although one or two staff who were clearly new on shift weren't quite sure where those changes had occurred, but certainly everyone was very clear about how ultimately to escalate, including to yourself, Arlene, and the deputy chief nurses, and your posters are very visible with your telephone numbers at any time call. So that's clearly that message has got through.
Thank you, Peter. Thank you. I think that's it for our 15 steps this time. Once again, as always, lots of useful information. So we've got 10 minutes. Nigel, is it very quick?
I'd like to comment on my own 15 steps recently. As some of you may know, I had occasion to attend to my mother-in-law, 80-year-old. She was in Britain Ward over December, January period, extremely well looked after, nothing but the highest of praise. Unfortunately, she then contracted an infection and ended up in Tudor Eid Ward at the middle of February. The care was disastrous, and I'll tell you exactly why. There was a lack of coordination between people there. When you asked how things were going, they didn't know, they had to go and find somebody else, blah, blah, blah. The ward next to, she was originally in a ward of 4. She was then moved out of that ward because allegedly novavirus had occurred, because people had been actually moved up from another ward. This became an all-male ward. Novavirus was in there, 4 people with novavirus. My son and my wife then visited. They got gowned up to go into the ward where my mother-in-law was, told it was novavirus. Who's got novavirus? My mother-in-law, allegedly. She hadn't, because that very morning she'd been cleared and she had no novavirus. So the whole thing was a complete shambles of communication. And just to finish this off, they couldn't expedite getting her out as quickly as possible, so she was sent home with acute diarrhea for 2 days. So all I can say is my own 15 steps experience, and it is actually verifiable, is disastrous for that ward. So something needs to be looked at in that ward. The nursing staff didn't know what they were doing between themselves. To announce that somebody's got novavirus when they clearly haven't, to get people gowned up to go in and see that person, not necessary, alarm, terrible experience. So I just wanted to record that.
I think it's important that Arlene and I reflect on your comments and feedback to the ward and really understand what happened, because your comments are deeply concerning. Thank you.
Yes, thanks. I think that the point about whether or not the norovirus is there, it's a very difficult one. Funnily enough, I had exactly the same experience as you with my mother-in-law in a different hospital where there were all the things we had to get gowned up, and then it wasn't there. So I don't think I'm not trying to make an excuse. What I'm saying is I think it's a difficult thing because it changes by the hour,
I fully understand
and but the point you make about communication is very important, and we'll take that on.
My problem actually wasn't so much that Novavirus was in the ward.
No.
It was the fact that this particular person, my mother-in-law, was the carrier of the Novavirus. And I don't know if that was the same as yours.
No, it wasn't actually, but it doesn't, you know, the point is the communication. And, you know, things happen at different times with different groups of people and they need to tell each other, and that's the point. Thank you. Look, we've only got 5 minutes. We haven't done the integrated performance report. That will take too long, but if there are any questions about the integrated performance report specifically, I'm happy to take them. So you've got it in your hands, Sandra, so it's probably about it.
It is exactly about it. It's just a comment, really. It was said earlier that the A&E and the ambulance handover times are really good now since they've enlarged both departments. In your own literature here, it's in red, and it says that your 4-hour wait time is only 85.1%, and it should be above 95. And your ambulance handover times are hitting bag numbers too. 30-minute waits, 285 people miss the 30-minute wait. So you're not hitting your A&E targets, you're not hitting the ambulance handover times, and that can only get worse when we only have one acute facility.
I'm going to stop those points because I knew you were going to raise those. So on the page you are on, right, look at the chart on the bottom right-hand corner, which is called handover times over 60 minutes.
Yeah.
So I don't know, it's the one that...
12.
As if got a page.
Page 12 of 34.
Right, so there's a chart of handover times from the ambulance over 60 minutes.
Yeah.
Look at January, which is the column on the right, the last one, and then go back 12 and look at January 12 months ago, and look at the very big reduction in ambulance handover delays. That is because we now have departments that are big enough to offload the ambulances in a timely basis. So then go and look at the A&E target and go up to the top right-hand picture, which says A&E 4-hour standard, and
you're missing them quite badly.
and look at the England and London positions, and you will see that we're still the third best deliverer of A&E in London. It has been a really, really hard winter, as you can read about in the press.
We've had no snow. It hasn't been a bad winter for any outside purposes. It's only been a bad winter because our NHS is being underfunded and cut.
So, but do you know what the biggest cause of why we're struggling to deliver the A&E standard? It's about staffing the workforce, and that's because
they're getting rid of them. And who's going to come and work here when you've been trying to close it for 30 years?
I think the middle grade problem in A&E is a really acute problem, and there are not staff available nationally for us to recruit, and I think the important point to note is that it does directly contribute to the delays we're seeing in A&E, and whilst we can put in place mitigations to make the unit as safe as possible, it remains a major challenge for us as a board.
You were saying in 2012 that you had to shut acute services. In 2012, you had to shut acute services in Epsom and St Helier because you didn't have enough staff. That was 7 years ago. If the intention was to provide us with a proper NHS, that was plenty of time to train up and promote those middle and higher level staff. It's not been done, and it's not been intended to be done. In fact, you've removed nurses, doctors, and you've really pissed off all these junior doctors.
So if I just make one, I just think it's important to make one. Just to make one point in the context of medical staffing, which is a problem we're referring to here. The number of medical staff who are trained is not within our gift to change.
No, but you should be feeding that back to the people who have that power. And that's really what we are.
And I'm really pleased to report we've got lots of positive support from Health Education England to make our staffing in the interim as safe as possible.
So you're going to stop the training in one or other hospitals?
Or both?
Sorry, but Sandra seems to be the only one that's been allowed to ask any questions. She keeps on going round in circles. I want to know, we're still dealing with this Brexit. How much does that have an effect on the staffing levels? I know we get a lot of staff from India, doctors and nurses, and the Philippines, but in amount of people coming to England to work in hospitals that are European, and surely that's got to happen. But it's not only the staff, it's also to do with medication. Diabetics medication comes from Europe. What impact is that really having on this?
Right, well, Peter, do you want to take that?
So I'll cover both components. So as a trust, we are reliant on and very supportive of staff from a whole range of backgrounds, whether that's international or from Europe. They are a very important part of our workforce, and we support them in that. As a trust, our position is slightly different from the national picture, where other trusts have lost large numbers of European workforce and are heavily reliant on those. We aren't in quite the same position. Some staff have left, but largely for other reasons around their nursing profession back in their own country and other things, rather than it being a Brexit component to that. So from a staffing perspective, our challenges around staffing are both every day but also long run, and so therefore we look for a variety of means of addressing that. In the short term, you also then talked about concerns around with medication and other things. So Dan Bradbury, our Chief Operating Officer, leads on the kind of all the work we're doing around contingency planning and other things. We are doing all that we can as a local trust to make sure that we are as best placed as possible, but many of the things that we need to rely on are being solved at the national level. So, for example, you talked about the diabetes medication and insulin. Those are the government and the Department of Health and Social Care has taken control to ensure that there are sufficient either stockpiles or alternative means of supply. All we can do is do all that we can within our gift to ensure that we are as best ready as possible. But it clearly is something that we are taking all the steps that we can do to ensure that we are ready for all possible outcomes.
Okay. So finally, Beth.
Right. I want to know how much of the acute services have been transferred to St Helier from Epsom, as so many patients, even with minor injuries, are now being transferred there.
Well, the answer to that is
surgery.
So nothing has changed about the disposition of services between Epsom and St Helier for several years. So years before I even started, so we're in excess of 5 years ago, Epsom Hospital stopped doing emergency surgery. It's in 2006, Ruth said, and it doesn't have a level 3 ITU. Nothing else has changed.
Planned surgery, some planned surgery is being sent over to St Helier.
So over time, more planned surgery for our trust is done here. We have been increasing the amount of people coming to Epsom Hospital for planned surgery, and less planned surgery is done at St Helier.
What about aftercare, post-surgery?
Well, so most planned surgery, you just go home because it's a day case.
Yeah, when you have to follow up and stuff
Well,
like that. Where's that happening?
So that happens on both sides. So if you have been, imagine you've been acutely unwell with a surgical issue and you live in Epsom and your acute treatment is at St Helier, we do our best to then have your rehabilitation back at Epsom, so that services like the Epsom at-home service, which enable you to go home more quickly, find it much easier to operate when all the patients there need to look after him are on this side.
And would that continue?
Oh yeah, we're expanding it. It's getting bigger and bigger.
People are going over there for planned surgery.
Only for the most...
consultants over there, and they say it's not safe here.
But only...
So I think what might be helpful best is to go through individual examples if you have them. I think what would be helpful is to get your feedback with the service users' permission about individual examples, because there has not been a change in direction in terms of how we undertake our elective surgical care for our adult patients. So be very keen to get the feedback you've got.
Right, and can we have plans of the proposed acute services on each of the 3 sites and their costs, please?
Well, so I think that is, you need to wait for us going out to the NHS to go out to public consultation when that would all be available.
We had it before when you were doing your engagement, you gave us figures, you gave us facts. Now the CCG seem to have taken over that job. we're going straight into a public consultation without being given any of the detail that we got from you before you sent it up to NHS England. Can you explain why there's a difference?
Yes, because the CCGs aren't allowed to go and consult the public until the government have said the money is available to build a hospital.
I'm not talking about consultation.
But that's why you haven't seen it, right? So if the government says, do you know what, Epsom Sneller, we're not going to fund you to have a new acute hospital,
Right.
there won't be one. So there's no point putting lots and lots of information in the public domain.
But you
So,
didn't have that assurance when you published a lot of detail.
But that's
Why
because-
aren't the CCGs publishing this detail in the same way?
because what we were trying to do was make the case to say, do you know what, there is a really big need to have a new hospital for our...
It's not a hospital, it's just an acute facility.
Well, okay, it's 500 beds of hospital building to look after you when you're most sick. I think most people would say that was a hospital.
You
But
didn't plan 500 for Epsom.
so we were trying to make the case as a provider, right? We are not allowed, as a hospital trust, in the way that NHS operates, to consult the public. The CCGs have to consult the public. They will put all the information into the public domain if they are told that the government will build us a new hospital.
You put all that information in the public
Yes.
domain before a consultation was planned.
But that's because we were trying to engage
But
you
said were
in the
going to have a
future.
consultation. You said you were going to have a consultation.
So the rules say the CCGs have to do a formal public consultation. That's the law.
Right, thanks very much, everybody, and hopefully we'll see you next time in April.